We are live.
Good evening. Welcome to iFocus Lecture 71. We are continuing with our International Cornea Masterclass series as part of iFocus Online. Today is the 9th lecture of this series, and the keynote lecture today is by Professor Terrence O'Brien. I would request Rolika Bansal to introduce him.
Sure, sir.
You can share your screen, Rolika.
Is my screen visible, sir?
Yes.
Okay. Professor Terrence Patrick O'Brien. He is a professor of ophthalmology and holder of the Charlotte Brer Rogers Distinguished Chair in Ophthalmology at the Bascom Palmer Eye Institute of the University of Miami Miller School of Medicine. He is director of the Cornea and Refractive Eye Surgery Services at the campus of the Bascom Palmer Eye Institute in the Palm Beaches. Dr. O'Brien is an internationally recognized expert in corneal, anterior segment, and refractive eye surgery, as well as in ocular infectious diseases. Dr. O'Brien graduated summa cum laude from the University of Michigan Medical School and completed ophthalmology residency at the Wilmer Eye Institute of the Johns Hopkins University School of Medicine. He then completed a fellowship in cornea and external diseases at the Cullen Eye Institute of the Baylor College of Medicine in Houston, Texas, prior to returning to Johns Hopkins as the Assistant Chief of Service at the Wilmer Eye Institute. Dr. O'Brien served on the full-time professional faculty at Johns Hopkins School of Medicine for 15 years and was the inaugural Tom Clancy Professor of Ophthalmology. Dr. O'Brien was recruited at Bascom Palmer Eye Institute to join the distinguished faculty and to help build the campus of the Bascom Palmer Eye Institute in the Palm Beaches. An experienced clinician, skilled surgeon, gifted educator, and prolific scientific investigator. Professor O'Brien has an active clinical and surgical practice in cornea, anterior segment, refractive surgery, and complicated intraocular lens surgery. He has been a leader in advancing newer technologies for advanced customized cataract surgery, including femtosecond laser-assisted cataract surgery. He is a Senior Honor Achievement and Lifetime Honor Awardee of the American Academy of Ophthalmology and past chairman and board member of the AAO's Refractive Surgery Interest Group and International Society of Refractive Surgery. He is Executive Vice President of the International Conference on Ocular Infections and the past President of the Ocular Microbiology and Immunology Group. It is an honor to have Professor O'Brien as part of the International Cornea Masterclass Series at iFocus Resident Education Program. We welcome you, sir.
Thank you, Rolika. Professor O'Brien, you can share your screen and start your talk. Sunil, can you unmute Professor O'Brien?
Yes, sir, I'm doing.
Great. Good evening. Can you hear me?
Yes, yes, sir.
Great. Thank you very much for that very kind introduction, and especially to Professor Hanavar for including me among this distinguished faculty for this important iFocus International Masters Series in Cornea. And I'm honored to be one of the participants and to share some of our information that will hopefully be of interest for this particular forum in cornea. And when Santosh and I spoke about the subject matter, we talked about several important areas in cornea that were of interest. And not sure why my slides aren't advancing. Just there we go. Looks like we're back on. And I'll share some of our experiences from here at the Bascom Palmer Eye Institute and from my experiences at the Wilmer Eye Institute at Johns Hopkins over the past 30 some years. And there's a reason I discovered why it's called cornea and external diseases, because often the external diseases will influence the cornea due to the proximity of the cornea with the adjacent structures. I have no faculty disclosures to report for this particular information that we'll share this evening. Well, 2020 was to be the celebratory year of ophthalmology and the year even designated for ophthalmologists, but there was another player that came on the global scene, and that was SARS coronavirus 2 that abducted the year and made 2020 largely the year that wasn't for all individuals in the world, including in ophthalmology. So we're looking forward to 2021 being a brighter, happier year where we can share information. And we've learned to evolve with infectious diseases over time to keep the human race moving ahead. The subject for today that Santosh and I ultimately decided on was one that often is full of myths and mysteries. And this isn't a political subject, but rather an important medical subject in external disease, and that's namely blepharitis. I think this whole series is about knowledge, and we can learn a lot from one of the most amazing individuals of the 20th century, Helen Keller, who told us that knowledge is love and light and vision. And hopefully over the next hour, we can share knowledge together and impart knowledge with each other. I'd like to take this time to undergo a systematic journey to the approach for diagnosis and therapy of blepharitis. And interestingly, although we know this to be an extraordinarily common condition, we really don't have well-controlled epidemiological studies to tell us the exact prevalence of this condition that is so common around the world. Certainly, although blepharitis is frequently overlooked, we know here in the United States that both ophthalmologists and optometrists both report that blepharitis is commonly seen in 37 to 47% of patients prospectively. And blepharitis is often the initial motivation for seeking treatment among our patients. Several studies in certain patient populations, including those undergoing cataract surgery, indicate a very high prevalence of blepharitis, with people in this one study of patients undergoing cataract surgery, an overall prevalence of 59% having blepharitis. Another study from the retina population with age-related macular degeneration showed that in this population, 86% of patients reported experiencing blepharitis symptoms, and 93% of patients with macular degeneration had clinical signs of blepharitis. So even our colleagues who are so poised for intravitreal injections have to pause and look at the lid margin and pay attention to external diseases. Myth number one, blepharitis is a complex subject. Well, certainly it can be complex, especially in academia, where we have those who would lump everything together into one category and those who would split everything into separate categories. And this has caused some confusion over the years with classification of blepharitis. I think as ophthalmologists and eye care providers, we can think of blepharitis by its literal definition, inflammation of the eyelids, but we have to distinguish the skin of the eyelid, which is dermatoblepharitis, and often we may be collaborating with dermatologists or other subspecialists, oculoplastic specialists, when we are talking about inflammation of the lid margin that may be due to infection, allergy, connective tissue disease, or other dermatologic diseases, like this patient with seborrhea and dermatitis spilling over to cause blepharitis. Another patient with a connective tissue disease with discoid lupus, and we can see these skin sign findings with inflammation of the skin of the eyelid. A patient with atopic disease, with atopic dermatitis, and you can see these signs often associated with frequent itching and eye rubbing. A patient with psoriasis who also has dermatitis spilling over to affect the eyelids, and we can see even the lower lid ectropion from chronic inflammation. And a patient who has a hypersensitivity immune contact dermatoblepharitis from a cream that came close to the eye and involved the skin, leading to this hypersensitivity and immune contact reaction. More often than not, though, as ophthalmologists and eye care providers, we'll be focused specifically on the lid margin because that's where literally the blepharitis occurs. And we can divide this anatomically into anterior and posterior based on the anatomy of the lid margin that includes the skin and the cilia inserting into the eyelid. And then as we go posterior, we see the Meibomian glands and the tarsal plate and the mucocutaneous junction that is typically part of posterior lid margin disease. So anterior, that involves the skin and the cilia, can be infectious, and certainly that can include bacteria, viruses, and even parasites. And the pathophysiology of blepharitis can include inflammation as a common theme that may be microbial induced or due to a fundamental problem of lipid biochemistry, and that is Meibomian gland dysfunction. So the pathophysiology of blepharitis involves any combination of these factors, whether it is anterior or posterior. We can see that for anterior blepharitis, there are these dermatologic conditions, allergy, seborrhea, rosacea that can spill over into the eye, bacteria, and even parasites that may infest the lid margins and lead to chronic inflammation. This isn't a political map of Democrats and Republicans here in the United States, thank goodness. Otherwise, this would maybe become even more contentious and more mysterious and full of myths. But actually, this is the distribution of gram-positive versus gram-negative bacteria that have been recovered from patients with blepharitis. And we can see that from our laboratory here at Bascom Palmer, a vast majority of the organisms recovered are coagulase negative staphylococci, or even coagulase positive Staphylococcus aureus, accounting here for 83% of the cases of organisms. And then we can even see other gram positives that are less frequently identified, Streptococcus pneumonia, other gram positives accounting for 7%. And then gram negatives may be recovered in less than 5% of cases. That can include Haemophilus species, Moraxella, Acinetobacter, and others, and even relatively facultatively anaerobic organisms like Propionibacterium acnes, as formally designated. This is a picture that we sometimes see or frequently see in the clinic. And certainly this isn't an image that you want to observe as you're bringing a patient for an elective refractive eye surgery like LASIK, or even into the operating room for a cataract surgery, because we can see the marked crusting along the lid margins and lashes. And if we obtain a culture from this material, we will find a smattering of organisms, just like I've shown from our microbiology laboratory, indicating colonization of the lid margin with a variety of microorganisms. So the pathophysiology here has always been somewhat confusing as to what role these normal lid flora play in the pathophysiology of anterior blepharitis. Certainly, this is an inflammatory condition by definition that involves the lid margin and the eyelashes. We tend to recover mainly coagulase negative staph. The inflammation has been thought to somehow be related to the microbes or their related exotoxins and enzymes that are released, bacterial lipases, and even immune reactions to various products such as alpha-ribitol teichoic acid that is part of the cell wall in these gram-positive bacteria. Now, staphylococcal infection can be purulent or even ulcerative, and often it can cause an angular blepharitis that's a focal infection of the skin of the lateral or medial canthus. So the clinical presentation is something that you're seeing every day, and many clinicians overlook these common symptoms and signs that are part of the typical clinical presentation. We have to learn to be able to judge the severity of the process and grade the lid margin in terms of the redness, normal, mild, moderate, severe, or very severe. And this can help us understand the condition better. And certainly if we're studying blepharitis as part of a clinical trial, we have to have an accurate grading to judge any response to therapy. So redness of the lid margin in some patients may be very mild, but in other patients it's quite significant. And in fact, it's the redness that brings them in because of the cosmetic appearance that often is upsetting to the patient and also to those who are observing the patient and seeing the redness. One of the problems historically has been that not everything follows a strict anatomic line dividing the lid margin in half between the anterior portion and the posterior portion. So many patients may have both anterior and posterior lid margin inflammation. So mixed blepharitis is certainly part of the spectrum in our patients. And again, we try to look very carefully to judge which portion is more significant, because the treatments for anterior and posterior, as we'll see, may vary considerably. So a mixed pattern is quite common indeed among this population. Another myth and a problem is many patients are rather nonchalant or indifferent to this condition, and they just think, well, it's blepharitis, blepharitis is blepharitis. However, blepharitis, especially of the anterior type, as we'll see, comes in several packages, and we need to be keen clinical observers to be able to make the diagnosis properly and to also monitor the related structures, including the cornea, which may be involved in many of these cases, as we'll see. Here was a gentleman who came to us who had complete loss of the eyelashes, matarosis. You can see the marked scarring and ulceration along the lid margins, hyperemia of both the tarsal and bulbar conjunctiva, and was very upset by his overall condition. So another myth is that microbial cultures in blepharitis are never really helpful for the clinical management. Yes, it's true, results may yield positive growth of the normal lid flora, making an interpretation challenging for the clinician, but quantitative cultures may often provide more useful information in select cases that can help us determine the extent of bacterial colonization, and in certain cases, even antimicrobial susceptibility testing may be helpful for those chronic recurrent cases that have been recalcitrant to therapy. How do we culture? Well, often you will use a sterile swab that is moistened in a microbial broth, such as thiol broth or thioglycolate, tryptase soy. And then we have to be careful where we are culturing to be sure we're getting the lid margin and not the bulbar conjunctiva or the tarsal conjunctiva. And then we have to be mindful of our own flora from our skin, like you see here in this old teaching slide, where maybe some of this sampler's own digital flora are going into the broth, and that will make the results of the microbiology cultures somewhat difficult to interpret. Back to our patient who has this severe ulcerative dermato-blepharokeratoconjunctivitis even. We did obtain cultures from the lid margin very carefully. The patient had seen numerous ophthalmologists and was not responding to multiple different antimicrobial therapies. But the cultures here grew heavy methicillin-resistant Staphylococcus aureus, not coagulase negative, but MRSA. And when we switched the patient to vancomycin, the lashes return and the ulcerative dermato-blepharokeratoconjunctivitis resolved. Another myth is that blepharitis is just a benign, self-limited condition. Yes, in many individuals, the condition may follow a chronic, relatively asymptomatic or minimally symptomatic course without causing troubles or sequelae. But in some individuals, chronic recurrent blepharitis associated with acute flares of major disease can affect the cornea and even visual acuity. And that's why we call it cornea and external disease, because you can see this patient who has a red hot eye. You can see 4+ diffuse bulbar hyperemia of the conjunctiva. The lid margin has telangiectatic vessels. There's some crusting of the cilia and the lid margin. And then notice this spillover into the peripheral cornea where there's an intervening clear space here at the limbus, but this peripheral infiltrative keratitis that is non-ulcerative at this point. But this is a type 3 immune hypersensitivity reaction that is really an antigen antibody response. And it was Bartley Mondino who years ago did some animal studies to detect what was the antigen, and it was a microbial antigen from the gram-positive bacterial cell wall of Staphylococci, alpha-ribitol teichoic acid. And this is what's spilling in and creating this type 3 immune response in the peripheral cornea. Here seen in another case where you see multiple peripheral areas of this, sometimes called staphylococcal hypersensitivity keratitis, because while it is microbial related, it is not technically microbial keratitis, but microbial induced immune keratitis due to the alpha-ribitol teichoic acid. So these bacteria on the surface are important, and we try to eliminate them, not completely, but just to reduce excessive colonization. And over the years, there have been many myths about the optimal way to reduce colonization and to control inflammation. So frequent detergent-containing scrubs were thought to be optimal, such as baby shampoo and other detergents. But we found over the years that the detergents can be somewhat toxic because they can break down meibum as a detergent. These soaps can break down meibum into free fatty acids and soaps that can be quite irritating. There's a number of commercially available scrubs throughout the world that have come over the years. So in your area in India, I'm sure you have many innovative products that your patients can use to try to cleanse the lids and lashes in a lid hygiene program. But sometimes patients overuse those, and the detergent or the cleaning itself can become an obsessive compulsive ritual that can add inflammation, irritation, and toxicity. Some of these products contain plant-based natural derivatives that have antimicrobial and anti-inflammatory activity. This is one substance, linalool, that's naturally occurring in plants, and it's used in many personal care products because it has a very pleasant floral scent. It's found in a lot of flowers and plants and even in tea tree oil. And it does interfere with microbial respiration and increasing bacterial and yeast membrane potassium permeability, hence an antimicrobial effect. This has been studied by the late Jeffrey Gilbard, who was interested in the activity against lid flora. And this product that contained linalool compared to a vehicle control and 10% polyvinyl pibroladone iodine was shown to be very effective against methicillin-resistant staph. This is the kill curve time. And we can see here that this linalool has a very steep curve and is very effective and less toxic than the povidone iodine. Another natural-born killer is hypochlorous acid, which is present in our human neutrophils as part of the body's immune response. It does have a potent microbicidal effect, and it also neutralizes toxins to have an antimicrobial effect and helps suppress the body's immune response. This has been shown to have excellent activity in vitro against a broad range of pathogens with fast-acting effect against the common flora of the lid and lashes. And it's been tested against Staph aureus and has been found to be extremely well tolerated with low toxicity, 1,000 times less toxic than povidone iodine, but yet excellent in vivo activity compared with other lid margin products. So certainly these lid hygiene products can help control lid margin colonization, and they should be part of a maintenance routine in many of these patients. Now, another myth or fact that's caused a lot of controversy over the years is whether certain types of blepharitis might be due to mites, and certain parasitics or ectoparasitic organisms in the Demodex class, like Demodex folliculorum or Demodex brevidis, have been found in a very high percentage of patients, especially increasing with the patient's age. And these organisms have a life cycle on the skin around the eye, the eyebrows, the lids, and especially the lashes. And these organisms can often be found among cylindrical dandruff that is present on the lid margins. And we can see this cylindrical dandruff shown here. And if we pull one of these cilia, this isn't moving, but this organism could be seen crawling or making its way along the eyelash. Doesn't seem to be working, but one of the clinical signs that you want to look for is this diffuse cylindrical dandruff that is present on the cilia. And this is a hallmark clinical sign with greasy scales that it has been associated for many years with the presence of these Demodex organisms. Another myth is whether angular blepharitis is always due to Moraxella species. Yes, in some immunocompromised individuals, people with excessive alcohol and other immune compromise may have Moraxella, but as we saw earlier, staphylococci may also cause this angular blepharitis due to the delicate nature of the skin at the lateral and medial canthus. Here is an interesting case that disproved another myth, that chronic follicular conjunctivitis is chlamydia until proven otherwise. This very pleasant lady who was not sexually active for many years, being a widow, was seen by a number of doctors who thought that this chronic follicular conjunctivitis was due to a sexually transmitted infection, and they wanted to refer her to a STI clinic and treat her for a sexually transmitted condition. But I think if we look carefully and try to see the forest between the trees along her lid margin, we can see this central umbilicated lesion with a keratin core that is due to a particular virus that can cause chronic follicular conjunctivitis. And these have a way of hiding between the lashes, and the patient was treated with multiple medications and didn't get better. But simply removing this this umbilicated core and creating some bleeding with a sterile 25 gauge needle allowed this process to resolve due to molluscum contagiosum. So chemical cautery used to be used, like silver nitrate and other chemicals. They can be toxic and even cause corneal burns. So we found, again, just unroofing this lesion, this molluscum lesion with the molluscum bodies that you see here, and unroofing and clearing it out to create a little bleeding will allow this chronic follicular conjunctivitis to resolve. Well, another myth here, and I'm beginning to get a little bit of a pruritic sensation as we see this anterior blepharitis that maybe some of you have a diagnosis for from looking along the lid margins carefully. But it brings us to the myth that all crustaceans originate from the sea. Well, unfortunately, as this case demonstrates, some of these organisms are not from the sea, but maybe from a little bit further south in the pubic triangle. And here we can see the pubic louse clinging to the cilia. And it's usually the female louse that has just the right diameter of the legs and appendages to hold on to the lashes and to make the way across the lashes in order to lay the eggs and the nits that are often seen in these cases of a sexually transmitted infection that can involve the anterior lid margin and spill over into the eye to cause inflammation. Now, another myth, and some of you, I know it's late there in India, but during your clinic, you might see a case like this and you think, gee, I wonder if I could bring this patient over to the YAG laser and treat this ectoparasite with the YAG laser. Although that might be a fun way to make the clinic go a little faster, actually these organisms are better treated with some ointments that can suffocate them and remove them. And don't forget, the patient does need to be treated elsewhere in the body, and any sexual contacts need to be treated as well. Well, anterior blepharitis has been tricky enough over the years, but one of the things that has puzzled me in ophthalmology for several decades is posterior lid margin disease, or posterior blepharitis, especially the condition known as Meibomian gland dysfunction. And we've got some of the brightest minds here in India on this eye course this evening there. And hopefully in the last part of this lecture, we can look at the posterior lid margin and develop an international consensus on Meibomian gland dysfunction. I was privileged to be part of an international panel, the International Workshop on Meibomian gland dysfunction. And it was interesting that an international panel of experts really spent a lot of time even defining what is Meibomian gland dysfunction and all of the associated clinical parameters that go with this. And this was a very interesting exercise. And I learned that sometimes it's difficult to come to consensus, even with very distinguished scientists and clinicians. So consensus is a noun that means a general agreement, a consensus of opinion among judges. But we might also think that con can mean against sense. And some of the myths over the years have been somewhat against sense or even nonsensical when it comes to Meibomian gland dysfunction. The classification of Meibomian gland dysfunction is shown here. And again, this can seem rather daunting when you look at it on first glance, but I think there are several forms of Meibomian gland dysfunction that we see that can lead to a hypersecretory state, an obstructive state that can be cicatricial or non-cicatricial, and even a hypersecretory state that can be primary or secondary. So this has really truly been one of the mysteries that has plagued clinicians and has made me puzzled over the years, because we'll have patients who have seen multiple doctors. They've tried many different treatments. They're willing to come and wait hours in the clinical waiting room, waiting to be evaluated. And yet when you take a look, often under the slit lamp biomicroscope, you wonder what is it that is causing such either significant symptoms or the patient's signs. But many times the signs are minimal, yet the patient's troubles and problems are quite significant, and it's really interfering with their life, their activities of daily living, and certainly the quality of their overall existence. The pathogenesis of posterior lid margin blepharitis is also involving microbes, but we don't understand the exact extent quite as well as we do with anterior lid margin disease. We know that bacteria may play a role. Certainly we see acute internal hordeola, a possible role of bacterial in chronic meibomian gland dysfunction. As I mentioned, particularly secretion of toxins and bacterial lipases that can enzymatically break down meibom, as we talked about. Obstructive meibomian gland dysfunction is where there's an actual anatomical blockage of flow, where there's epithelial hyperplasia along the meibomian gland orifice, thickened secretions, and even cicatricial changes that may lead to severe evaporative dry eye and corneal scarring, as we'll see. Hypersecretory meibomian gland dysfunction is like a dysmeiboria, or sometimes a meibomian seborrhea, that has often been associated with dermatologic conditions, including rosacea and ocular rosacea. This is from our MGD workshop that looks at the pathophysiology of obstructive meibomian gland disease. And as you can see, there are changes of hyperkeratinization, increased viscosity, obstruction that triggers a cycle of inflammatory processes that ultimately can lead to atrophy of the glands, loss of glandular function, and certainly changes of the quality of meibom and the quantity of meibom that can destabilize the ocular surface and lead to certainly difficulties with contact lens wear. Other dry eye may be arguably one of the most common forms of evaporative dry eye. And again, these are signs and symptoms you hear from the patient every day, the signs you see when you look. Here you can see this chronic hyperemia of the tarsal conjunctiva, lid margin telangiectasias, often areas of dropout where there have been prior chalasia with scarring, and this can spill into the tear film. The lid margin has these telangiectatic vessels, often unhealthy cilia spilling across from the posterior lid margin to the anterior lid margin. And one of the hallmark signs that you want to be looking for as a clinician is the presence of these soaps, as you see here, that are present along the lid margin and towards the medial canthus. And here we can see at higher power. And this is the visualization of the enzymatic saponification of meibom into the free fatty acids and soaps due to bacterial lipases that are present along the lid margin and the anterior and posterior lid margin. And these free fatty acids and soaps are highly irritating, often mediating the extreme burning that these patients complain about. Now, these are the normal arrangement of the meibomian glands in both the upper and lower lids. And these should have a piano key-like regular anatomic normal arrangement in a healthy lid, so that the function of the upper and lower meibomian glands may be normal in these patients. We now have had a revolution in ocular imaging, not only of the posterior segment of the eye, but of the posterior lid margin of the eye. And that's thanks to these advances in interferometry and being able to visualize the glands with high resolution. This lipid layer interferometry that is commercially available is a quantitative and qualitative measure of the lipid thickness, the layer of the thickness of the lipid layer and the blink. And it's been shown that a lipid layer thickness less than 60 nanometers has a 90% specificity for Meibomian gland dysfunction. These units can also perform meibography and look at the tear film layer. Here we see the Meibomian glands through infrared imaging, and you can see these glands present along the lower lids. But with dynamic Meibomian gland imaging, we can have devices that are easier to use in the clinic and look at these spectacular views of the Meibomian glands that we can share with our patients to show them what's happening dynamically over time to their Meibomian glands as we apply treatments. And often a picture is worth 1,000 words. And if you can show this to your patient in the clinical examining lane, they have a much better understanding of what it is we're trying to achieve with our therapeutic approaches. This uses several light sources to take multiple images and combines them together so that we can stage the severity based on this imaging. Here on the left, you see an early stage Meibomian gland dysfunction, non-obvious MGD, but if you try to express, you'll see there is MGD, and you can see some changes in the glands. In the middle, we see later stage MGD with severe dry eye. And look at the dropout that we're already seeing of the Meibomian glands using this dynamic meibography. If we look all the way here on the right, you can see the consequences of unchecked, untreated Meibomian gland dysfunction. And that is a permanent loss of the glands with severe atrophy. And these cases do not respond well to therapy because the glands have sadly succumbed to the chronic inflammation. So look for non-obvious MGD, and if you express, you will often see the little fine toothpaste expressions that are there. And you can see recalcitrant obstruction in many of these cases in the mild early stages. Here's normal meibography on your left. And then even in this relatively young patient of 23 years of age, it was the meibography that shows us, compared to the normal, that we are already in trouble in this young individual because of the severe atrophy and dropout of the glands. So the pathophysiology includes altered Meibomian gland secretions, as we said, cystic dilatation of the ducts and the acini, inflammation with hyperemia of the lid margins, edema. The role of bacteria is still controversial, but certainly toxins and enzymes play a role. And then the hypersecretory states with the dysmeiboria and seborrhea with rosacea is a separate category. Just like anterior lid margin disease, we need to be able to grade the severity to treat patients accordingly. And you can see here the swelling of the Meibomian glands along the posterior lid margin, and here severe disease with actual dropout of the glands even seen on slit lamp. Notice here the dysfunction of the meibum, the pace that can be expressed using a sterile cotton tip applicator or a commercial paddle. And even the anatomical destruction with chronic inflammation. Look at this severe dragging of the Meibomian gland orifices posteriorly. And this will create a permanently altered tear function and a lifetime of dry eye and misery due to this cicatricial Meibomian gland dysfunction. I mentioned in the pathophysiology of obstructive Meibomian gland disease, the role of keratin or hyperkeratinization. And here we see the Meibomian gland orifice, and this is a special stain indicating keratin. And you can see the hyperkeratinization of the Meibomian gland orifice that leads to an obstruction with stasis of meibum, lipogranulomatous inflammation, often chronic and recurrent chalasia. And this type of inflammation, the lipogranulomatous inflammation, can lead to permanent damage and loss of function. Here's the anti-cytokeratin stain proving it's the cytokeratin that is blocking these glands. So what is the pathophysiology and its role in ocular disease? Inflammation is a hallmark. That's why it's called blepharitis. Bacterial lipases alter the composition of Meibomian gland secretions. We have altered lipids that then affect the stability of the tear film, often a hormonal imbalance, and certainly aging plays a role in ways that we incompletely understand. The net effect is the release of pro-inflammatory and irritative effects of altered meibum onto the ocular surface, and that leads to the typical irritation, inflammation of the lid margin, and we see destabilization of the tear film, accelerated evaporation of the aqueous tear layer, and ocular surface inflammation. One of the principles that is often overlooked among treating clinicians who are just trying to help the patient and really help get them out of the office as quickly as possible is the realization that Meibomian gland dysfunction is chronic. I think Professor Meibom would have realized that. And also, as we've learned over time, not only is it chronic, but it's progressive. And we have to begin to think of Meibomian gland dysfunction maybe a little bit more like we think of glaucoma, certainly a sight-threatening disease of great severity, and a progressive glaucomatous optic atrophy, or if we don't treat the Meibomian glands, just like if we don't treat glaucoma, are we going to see a gradual loss of visual field and visual function? So remember this picture when you're seeing even younger patients earlier in the stage, and remember and think of progressive atrophy and dropout of the glands that will not be possible. At this point, the game is over, and there's very little we can do to help this type of patient. The features of chronic Meibomian gland dysfunction include lid inflammation, ocular surface disease, so pay attention to the cornea and the ocular surface, and importantly, evaporative dry eye. We used to think of the tear film as a sandwich of aqueous between meibum and mucin. That's certainly a very simplified view that we now know is grossly oversimplified, and that we're dealing with a complex anatomical structure that forms the preocular tear film. And certainly the role of meibum and the Meibomian gland secretions is crucial to the stability of the first layer of the tear film that will prevent evaporative tear loss and severe ocular surface instability. So dry eye disease is something that you should be looking for as a common accompanying feature in patients with posterior lid margin disease. And we can now measure the tear volume quite accurately using anterior segment ocular coherence tomography. And we can measure the true precorneal tear film thickness. And a lower tear meniscus height has a diagnostic sensitivity of 92% and a specificity of 90% for dry eye, and a strong correlation with the symptoms. And there are a number of commercial machines, none of which I have any interest other than academically, in their ability to show us the tear film, and we can measure accurately the tear meniscus height and compare that with treatment. So evaporative dry eye can be due to intrinsic factors or extrinsic factors. We have to think in some parts of the world of nutritional causes with vitamin A deficiency, the role of preservatives, especially in destabilizing the tear film, contact lens wear, and certainly allergy, rosacea, and other conditions. Low blink rate can cause this, as well as the action of drugs that affect the meibum. Remember the basics of the Meibomian gland structure and function. The Meibomian glands are holocrine glands, and so the contents are actively expressed as the mature cell dies and becomes a secretory product itself for the ocular surface. So we want to think of this picture in our mind of the meibum being released from this holocrine gland, and that has to go smoothly in order to avoid these pathophysiologic conditions that can lead to the atrophy and gland dropout. So in our last few minutes, what is the current therapy for Meibomian gland dysfunction and posterior lid margin disease? Well, you just have to talk to your patients to realize that the satisfaction among those patients suffering from chronic Meibomian gland dysfunction is not as high as we would ideally like. And artificial tears, even lipid containing, omega-3 essential fatty acid supplements, localized physical therapy and hygiene, oral antibiotics, topical antibiotics, and even corticosteroids, all in a multifaceted approach, are often needed to try to control and prevent the chronic progressive cycle of destruction of the Meibomian glands. Now, we all know steroids have both positive and negative effects. We only have to look at our former governor in the state of California, who is a famous international movie star. Here he was before, I'll be back. And then after the use of steroids, it's, oh my back. So steroids have some negative effects, certainly on the eye. Cataract formation we can take care of. Secondary glaucoma can be dangerous with a chronic disease with chronic steroid use. Certainly potentiation of infection with herpes virus, fungal disease, which is so prevalent in India, mycobacteria, and delayed wound healing that can lead to perforation of the cornea. Remember, external disease and cornea. So physical therapy is now getting more attention, and something we probably should treat more like our colleagues in orthopedics and orthopedic surgery as a special discipline of ambulatory medicine. We know that expressing the Meibomian glands can have a favorable effect to eliminate that obstructive process that we talked about. So in some way, physical therapy may benefit patients. And which of them benefit? Well, those whose Meibomian glands are compromised, but yet they're still functional. So we want to get it early on and apply physical therapy to Meibomian gland dysfunction. Certainly at the slit lamp, diagnostic expression is important to ask yourself, is there flow of meibum? If not, go to meibography to look as to whether the glands are present. And if they are, we can do probing. If not, then we need a different approach. So the goals of physical therapy are to improve the quality of meibum and the flow of meibum, to reduce symptoms and improve signs, arrest the progression and prevent atrophy, all with the idea of improving the quality of life for these patients. Maybe our certain cultures, like the Japanese culture, here we see the oshibori frequently offered to guests at the time of a meal or greeting, with a warm compress to apply to the face. So we should think of this more like our dental colleagues and dental hygiene, that our lid margin needs a lid hygiene on a frequent basis, just like flossing our teeth, brushing our teeth, with heat and massage as the goal. Now, unfortunately, as this data shows, warm compresses alone often do not achieve a sufficiently high temperature for a long enough duration to be effective. And eyelid washing may help, but it may not be fully complete. So there are now gel masks that can be heated in the microwave that can stay warm for a longer period of time to provide greater effect. Manual expression can be done, as I showed in the clinic, with the a cotton tip applicator, forceps, the Mastrada paddle. There are a number of commercial forceps that are available that help you to gently express meibum. You don't want to crush the glands and create more inflammation, but the patient may have some discomfort with this, and there's the cost of the device. There are different physical therapy devices commercially available. Again, I don't have any commercial interest. The Meiboflow is a way to try to heat with thermoelectric heat in a gel for 8 to 12 minutes for a more even heating. There's micro-blepharo exfoliation treatment. It's thought that maybe there is a biofilm that can build up along the Meibomian glands, and sort of almost like an electric toothbrush, cleaning this off can help the flow be better. There are some positive effects both before treatment with micro-blepharo exfoliation and afterwards that have been reported. LipiFlow is a technologically advanced warm compress that applies both pulsatile thermal massage and heat at a specific parameter that's been tolerated well by patients and may be used with a 12-minute cycle per eye. It's simultaneous and hands-off. Here we see a patient undergoing this treatment, and both eyes can be treated simultaneously with a 12-minute cycle. The treatment results are shown here, and some patients may have an effect that's long-lasting. Other patients may need to be treated several times per year. The problem is the expense of the machine and the treatment. For those patients with true obstructive lid margin disease, we may have to probe to unroof the glands to get them working again. And a colleague here in the United States, Bascom in the Tampa Bay area, has made some commercial probes that allow one to unroof the glands and combine with other treatments that may be helpful. Here you see the use of this probe to break in, and there's often some bleeding and some pain to the patient, but in certain subsets of patients, this can help with the obstructive form of MGD. Intense pulse light therapy has been shown to be very effective for those patients who have ocular rosacea, obvious facial rosacea. It's not sure exactly how IPL or intense pulse light works, but some patients have reported positive experience. But again, this may be a costly intervention. So in summary, our treatment algorithm for Meibomian gland dysfunction is to first check for flow on compression with manual expression. If the glands are working, then we can go to hyperthermia or pulsatile hyperthermia. If, on the other hand, there's no flow when you're compressing on the glands, we go to imaging. The glands are present, then we would try to probe to get them working again. If there's complete atrophy and dropout on the imaging, that's where we may need to go to supporters of the ocular surface, such as scleral lenses or systems like the PROS lens to help support a very unstable ocular surface. So in summary, physical therapy is Meibomian gland dysfunction unplugged. Manual therapy is useful as a stepladder approach to the treatment of Meibomian gland dysfunction, usually when it's an at-home treatment that has failed. But we need more studies to better define the role of each of these specific modalities and the combination, timing, and spacing for optimal efficacy. Well, it was interesting to be part of that MGD workshop over 8 years ago. And the question we have in 8 years, have we made progress towards consensus? Well, I think myths and mysteries still persist. Hopefully we've debunked some of the myths and unraveled some of the mysteries here this evening. Unfortunately, this condition is extremely common and still underdiagnosed by clinicians. It's a frequent contributor to evaporative dry eye, chronic and progressive. Remember the progressive state. Think of it more like glaucoma. Patient education, motivation can be aided by imaging and showing them what's happening to their glands over time. A multifaceted medical and physical therapy approach is recommended, and a maintenance program is necessary to prevent progression and atrophy. I don't think we have consensus, but fortunately, there's greater awareness, and hopefully after this iFocus lecture, many of you great minds there in India will help us go further to understand blepharitis and eliminate the myths and mysteries. So I want to thank you so much for the great honor to be part of this program. And remember again, Helen Keller said, the only thing worse than being blind is having sight but no vision. So let's take a visionary approach to both cornea and external diseases. And I thank you again, and hope some of you will come and visit us here in South Florida during your training after the pandemic. And I thank our entire team here, and thanks to the organizers.
Thank you so much. It was the most comprehensive and insightful lecture I've ever heard on this topic. It's wonderful. We learned a lot today.
Thank you.
Harika, you have questions?
Yes, sir. Thank you so much, sir. We have few questions from different portals, sir. I'll take one by one. What is your take on using azithromycin versus doxycycline for the treatment of blepharitis, and what regimen do you recommend?
Excellent. That's an excellent question. Macrolides are, of course, antibiotics. Erythromycin was the first member of the macrolide family discovered in 1954 in soil. And then we had newer macrolides that were engineered to be even more potent and efficacious, and certainly have greater bioavailability. And that's one of the major advantages of azithromycin is its tissue bioavailability. It has also significant immunomodulatory effects compared to erythromycin. And certainly doxycycline has immunomodulatory effects as well. Doxycycline also has anti-collagenase and some anti-matrix metalloprotease effects, which can be beneficial with the inflammation. We often will use both. We'll use an oral macrolide with a topical macrolide. There is azithromycin 1% available as a suspension that can be used once or twice a day. It stays on the lid margins and achieves very high concentrations. And over time, that can be helpful, not so much for its antimicrobial effects, but more for the immunomodulatory effects. Doxycycline, the lipophilicity progressively increases as you go from tetracycline to doxycycline to minocycline. Minocycline is the most lipophilic among the tetracycline family. So for the most severe cases, we will frequently use oral minocycline, 50 milligrams twice a day for 2 or 3 weeks, then once a day for 2 or 3 weeks, and then stop. And frequently, these patients will require cycling a systemic course maybe 2 or 3 times through the year.
Okay, sir. The next question is, what association of ocular rosacea and blepharitis do you see in your practice? And is there any special regimen that you prefer for these cases?
Yes, there definitely seems to be an association, and that's part of that hypersecretory form of meibomian gland dysfunction, sometimes called seborrhea or dysmeiboria. And there is a skin component, so often collaborating with a dermatologist will help. There are dietary triggers that make things worse in these patients. Many times it's unfortunately the things that are are craved in the diet, like dark chocolate and sweets and rich cheeses, red wine, these things that are pro-inflammatory in the gut and in the diet. We've been looking too at the role of the microbiome on the lid margin and the ocular surface, and the role that that may play in chronic inflammation in some of these patients, and whether that could be controlled like other diseases where we try to influence the microbiome on the ocular surface. But yes, rosacea plays a role. You have to identify it, often treat with the dermatologist, avoid certain dietary triggers, and they will often require chronic systemic doxycycline and even erythromycin.
Thank you, sir. The next question is, how often do you see sebaceous gland carcinoma cases masquerading as Meibomian gland disease?
Well, that's an excellent question. And that's something you want to certainly always keep in the back of your mind, that not everything is infection or inflammation, but we can have neoplasia as well. And those can be a masquerade with pagetoid spread along the lid margin. Look especially in individuals who have had frequent recurrent chalasia that are non-responsive to conventional therapy. And if there's any doubt, of course, biopsy and histopathology are required to rule out that masquerading syndrome.
Thank you so much, sir. That was an excellent talk. I request any other panelists to please ask questions if you have one.
Sir, this is Dr. Lakshya, sir. So do you find difference in IPL and LipiFlow? So how do you find them different, and which one do you prefer?
A difference between LipiFlow and which?
IPL, sir.
IPL. The IPL we usually reserve for those patients who have severe atrophy of the gland. So we use the dynamic meibography. And if there's not gland function present, there's significant dropout of the meibomian glands with atrophy, that's where the IPL is preferred. If, on the other hand, the glands are still present, just not functioning well, or they have dysfunction, then the LipiFlow is recommended once or twice a year to apply that thermal pulsatile massage.
And how does IPL help if the glands are atrophic, sir?
Well, that's what I said. That's a little uncertain as to the exact role of IPL. Is it just the heat of the laser itself that creates hyperthermia? Some have implicated some effects of the laser and the healing from the laser on the lid margin itself and the function of the lid margin and evaporative tear loss in these individuals. But I don't think the exact mechanism of IPL is fully understood.
Thank you, sir.
Thank you.
Hello, Dr. Brian. This is Dr. Vikas. So thank you for an excellent talk and for such an important topic, because we also see here that blepharitis and MGD both are very much underdiagnosed and undertreated, and continuously patients are only on lubricants without being given too much of a diagnostic look repeatedly by the ophthalmologist. And I think it's very, very important that you brought it out, that so many key areas that we need to, that we oversee when we are treating patients simply as dry eye, but actually they require treatment of MGD or the blepharitis. So my question to you is that here often we find one of the very underdiagnosed condition is Demodex blepharitis, and it often is associated with MGD along with it. So what treatment regimen do you follow in these patients of Demodex, whether you do home-based therapy with tea tree oil or office-based? And secondly, do you routinely also patients of MGD who are not responding but may not have those collarettes, treat them for a little bit with the tea tree oil, as it might also have other anti-inflammatory effects as well?
Well, that's an excellent question. And certainly Demodex, as I said, has been controversial for many years. The association is well established, especially with increasing age. The prevalence of Demodex, the presence of Demodex is very, very high. But the exact role is incompletely understood. We nevertheless, especially when the cylindrical dandruff are present that I showed, we'll typically remove a cilia, and we have a microscope right in the clinic where we can easily make the diagnosis and then begin the treatment with tea tree oil as our mainstay, both in office and at home. As you said, I think it's important to do both. And then for many patients, even if we don't document the presence of Demodex, we will also use tea tree oil or that linalool because of the natural antimicrobial and anti-inflammatory activity without the concern of a selection pressure for antimicrobial resistance. So again, I think we want to be careful with using chronic exposure to antibiotics. So here's where these products with natural antimicrobial and anti-inflammatory activity are quite useful for maintenance therapy.
What percentage of tea tree oil do you use, sir?
Dr. Sheffer Sang here, who was at the Bascom Palmer Institute previously, has developed a commercially available, both a scrub and a solution that's very convenient for the patients to use. And we will often have them start using that 2 or 3 times a day and then go to just once a day for maintenance.
Thank you, sir.
Hi, good evening, Dr. Brian. Thank you for a nice talk and clearing all the myths and the mysteries. So after this talk, I have a different kind of a myth, because last I was told about the intense pulse light therapy, that my learning till now was always that it is to be used when you don't have a significant Meibomian gland loss areas on ocular surface analysis. Whereas in your experience, you're saying that you use it for those patients who actually have atrophic glands. So what are your criteria for treating patients with intense pulse light therapy, and how many sittings, and what are the patient results on that?
Yeah, so I think the results have been mixed. And again, as the earlier question brought out, there's much we don't know. So this is still part of the mysteries of treatment, especially for those patients who are more advanced, I think, and they're already losing or have lost significant function. This is one thing that has been tried. Dr. Rolando Toyos in Memphis, Tennessee, in the United States, has been one of the early adopters of this, and he has shown good results. I would say our results are mixed in this patient population, with some responding. They often will require 2 or 3 sequential treatments to gain any effect, but there's a substantial group of non-responders who probably don't get much significant effect.
And what is your approach to patients who have poor lipid quality on ocular surface analysis, but everything else being normal, are being symptomatic, you don't see any obstruction in Meibomian glands? How do you approach such young patients? There are a lot of young patients who have these problems.
Right, that's another mystery. And you know, like I said, I hope some of the great minds like yourself and others listening this evening can really work together and unravel the lipid biochemistry, because I showed that picture of the person who really looks pretty normal clinically, but is really quite miserable. They have a lot of burning, a lot of symptoms. They've seen many other doctors. There's not a lot of clinical signs, but clearly there must be some qualitative disturbance in the lipid. We do have some quantitative measures that I showed that we can measure now, but often those are normal. So I do believe that it's not just the quantity, but also the quality of the meibum that's important. And we really need to develop maybe some some on-site tests where we can measure some aspect of the quality. We do have the MMP9, that it's called the Inflammadry, where we can measure matrix metalloprotease activity as an indicator of inflammation, but that's only an indirect indicator. We need to really look at what's going on with the lipid biochemistry and figure out these subtle changes that are leading to subclinical or preclinical symptoms in our patients. And I don't think we're there yet. So I'm looking forward to the future where we'll be able to do that.
Thank you. Thank you.
Thank you. I think they're calling me back to the operating theater, so I'm sorry that I have to cut this short because I'm learning more from you as always than I may have imparted. But thank you so much again for the very kind invitation and for being part of this distinguished international master series on external disease and cornea.
Thank you so much for holding you back from your operation theater. Please do carry on. Thank you for your wonderful lecture, and we'll hope to have you back again sometimes.
Thanks so much, and all the best. Stay healthy.